I will. Oh, you all disappeared.
Amy, if you turn on screen share, you can usually just see a couple of people, but I wanted to welcome everyone and give a quick introduction to Amy, who can also introduce herself further, but I wanted to thank her for giving this talk because I know we always want amazing faculty from Seattle Children's and University of Washington to share their knowledge with our community. And Amy agreed to give this talk, Inclusive Communication in Action, which I think is so timely and appropriate. And I really admire Amy for many reasons, but Dr. Trowbridge comes to us by way of Seattle Children's. She's one of our faculty at University of Washington as well. And she now helps run the palliative care certificate training course, which is such a wonderful resource for so many in our community and nationally. And we really appreciate the graduates from the program as well. And we've worked with a number of them in the palliative care fellowship, in the work that we do here in Seattle and Washington. And so again, I just want to welcome Amy and thank her again. And Dr. Trowbridge, please again, feel free to expound on that introduction. But again, just so much gratitude for you giving this talk to our community today.
Thanks so much, Annie. Good morning, everyone. It's nice to see you all. For those of you who were in Montreal last week for AHPM, welcome back. Glad we can offer you some better weather here in Seattle. Thanks. Like Annie said, I'm one of the co-directors of the Palliative Care Training Center here at the University of Washington, which is a training program that was started initially by was Stu Farber's vision, and it's been an honor to get to be a part of the team to continue that legacy on. The work I'm going to be presenting today is work that's been supported by the Cambia Health Foundation in conjunction with the Palliative Care Training Center. A couple of years ago, they gave us a grant to continue some of the excellent work of Randy Curtis and Caroline Hurd and others on expanding access to palliative care through quality metrics and through education. And a couple of years ago, they said, we want to expand this to pediatrics. And so I've been lucky enough to work with an incredible team, which I'll tell you about in a minute, to think about how we teach primary palliative care skills in pediatrics, but also more broadly. And so what we are going to cover today, we're going to just start a little bit talking about the problem of sort of how we teach serious news and information sharing more broadly. I'm going to introduce you to a couple of the key aspects, I think, of culturally responsive and trauma-informed communication. And then we're going to spend the rest of the time going over a framework that we've developed that we think is additive to some of the other frameworks for information sharing, delivering serious news, with a key focus on the concept of information gaps and information readiness. And before I go any further, I just want to start with a thank you. This entire framework and all of this work has really been a labor of love and a partnership, in particular with the two incredible women you see on the screen, Arica Patnode, who is here, I see, thanks for being here, Arica, and Caroline Hurd. And a number of others, both at University of Washington and other places, have also contributed to this work in a number of different ways, including Nasli Avendini. So thank you to Nasli. This also, it will be a somewhat interactive talk. And so there'll be different moments where I'll be asking you all to put some thoughts into the chat. So I'll just give you a fair warning now that will be coming up in about 10 minutes or so. So just to kind of set the stage, I want to just talk a little bit about sharing prognostic information. And we've had a number of really incredible speakers at this forum over the last year, talking about this topic. And so hopefully much of this is review to all of you. In general, we hear clinicians say that, sharing key medical information, including prognosis, is difficult because they don't have enough time in their day. There's too many competing demands. They haven't been trained to do it. They're oftentimes worried in particular about cross-cultural communication. And we hear in particular in the pediatric population, they're really worried about taking away hope. At the same time, though, we also hear over and over again from these same clinicians frustration when they feel like maybe their patients or their family members don't get it. And we have a big advisory group that has helped inform this work, and we heard from them that they really felt like the skills that most clinicians are lacking these days are less about the specific words and more about the internal reflections and attitudes and sort of the ability to be able to think inward and self-regulate. And so that is a piece of where this work is coming from. We also look at the literature to say, what do patients and surrogates tell us? And we know that most, but importantly, not all patients want to hear information about their own or their child's condition. In the pediatric literature, this is really comes from the concept of a good parent literature, which is the idea of how do you be a good parent to a child with serious illness. And a lot of it comes with being informed and knowing what's to come. We also hear that parents almost always have a more optimistic prognosis than their child's doctors, and that, as Whitney Kiker and some other folks over the last year have really talked about, is a complex concept, and we'll talk a little bit more about that prognostic discordance. And then we hear parents and patients and surrogates say just how important it is that their medical teams hope alongside of them, and that often doctors seem to focus on the negative only. And I know a number of you were just at HPM and perhaps heard Ronit Elk or others talk about this work, highlighting the importance of hope alongside the patient and family, in particular for historically marginalized or minoritized communities. And this quote is from a parent who was participating in a qualitative study about prognostic communication after severe traumatic brain injury. And I think it really says it all about sort of this concept of the pessimism that sometimes families feel from physicians. I think clinicians' concern is that there's some kind of denial going on. They can't see how a full acceptance of how sick they are can exist at the same time as hope. People understand it when they say it's bad. You don't have to beat them over the head. So with this in mind, when we consider teaching information sharing, our focus has been really on finding the sweet spot where we're telling the truth in the ways that patients and families desire. Sorry, I'm also on call. Where we're telling the truth in the ways that patients and families desire without veering into a concept that I call information toxicity. And this idea, I'll talk more about information toxicity later, but this is the idea of giving more information despite cues that information is not needed or not helpful. And the work I'm going to present is informed really by three main bodies of literature. One is this growing field of communication science. This is the area within palliative care research that has been my deepest passion in my career. One major limitation of the research in communication science is one that I think is pervasive in many areas of research, which is the sort of homogeneous samples and populations that it draws from. And in pediatric palliative care in particular, most of what we know about communication and about prognostic preferences tends to come from white mothers. And so we need to be particularly careful not to generalize this data about communication, which is clearly so influenced so deeply by culture, to across the board, to a broader population. And so recognizing that we're still limited in this data as we continue to learn more about how to make this individualized, I'm looking to two additional fields: cultural responsiveness and trauma-informed care, to help guide the approach that I'm going to describe. These two fields, which certainly are not perfect, but they really come up from they really have a history of kind of coming up from the community rather than down from above. Cultural responsiveness comes from the groundbreaking work of Melanie Turvalon and Jan-Marie Garcia. And we really see trauma-informed care as foundational to culturally responsive communication. As many of you know, we had a talk, I think, a year ago about trauma-informed care from one of our fellows that was incredible. Really, the essence of trauma-informed care, as I've learned to understand it, is to assume everyone has some level of past trauma, maybe past healthcare-related trauma, and to try to avoid re-triggering that trauma in unsafe ways. And one of the leading voices in trauma-informed care is SAMHSA, the Substance Abuse and Mental Health Services Administration, and their work informs our approach. And what we've done, today we're going to focus on 4 key themes that come from these foundations and are really specific, we think, to communication. So first, I talked about this a little bit already: self-awareness and curiosity. This is really the foundation to everything that we know is necessary for culturally responsive communication. Second, affirmation, affirming the lived experience of our patients and families. Statements of affirmation not only help us build toward trust, but also can help us decrease our own implicit biases. Third, this idea of voice and choice, recognizing the inherent power imbalances between clinicians and patients and families. We really must be active in creating and elevating the patient voice or the family member voice at every opportunity we can. And of course, this is the bread and butter of palliative care. And then finally, accountability. All of this high quality communication is really for naught if we don't hold both ourselves and our institutions accountable every step of the way. We're going to come back to these 4 tenets throughout the talk and see how they apply in different settings. So just for a brief moment, as a curriculum design team, we've chosen to be really explicit in our design to not include specific cultures or specific groups of people. And we don't suggest that there is one way to share information that is default and another way that is culturally responsive. Instead, we really focus on where our commonly taught frameworks have broken down, in particular for populations that have been marginalized in the healthcare system for many years. And we've sort of taken that experience and created a framework that is meant to be inclusive and work for all populations. Our approach to teaching this, as you'll see, is by really choosing to explicitly label some of the broad categories of where the sort of fundamental frameworks that you may have seen in the past can go off track, and offering an alternative path in those broader categories. So with that, I'm interested, and I think I know the answer for a lot of folks here, but pop into the chat if you would. What are some of the communication tools that you have used to either teach delivering serious news or you have used in a clinical setting yourself to deliver serious news? Thanks, folks. I'm seeing lots of call outs to some of the different Vital Talk frameworks, guide and remap and nurse. I'm seeing some specific skills like assess and ask permission. I love that, Annie, asking permission a lot. Thanks, Jill, for throwing in there ask, tell, ask. I think many of us have learned that one. Thinking about using headlines, Lindsay, thank you. And Suzanne mentions reflective or recreating back statements. These are incredible, you all. And you all are obviously high quality communicators and will see that many of the things that you have brought up in there are going to come up throughout this talk. I have taught guide and nurse and remap and ask, tell, ask for many years. And I find that those particular frameworks oftentimes can get us kind of 80% of the way there. They work pretty darn well. There's a reason why they're kind of everywhere and they've stuck around. I think there are a couple of small problems with these frameworks. One is that they tend to not be explicit in how to adapt information sharing based on what a patient or family has already knows or has already heard. They, in that same vein, they don't differentiate between what a patient has heard and what a patient believes. And they don't account for hesitancy or reluctance or ambivalence or any kind of information preferences, really. And so that's what we sort of set out to try to create a framework around. And this is the flowchart framework that we're going to talk about today. You'll notice that this is focused primarily on really setting up the conversation. It ends at giving information or not. And we know that really a lot of good work happens after that step. This just isn't the focus of our work today. And so I'm going to start by showing you the basics of this because it really does line up nearly exactly with what you have already been teaching. And I'll go through this portion pretty quickly as this should all be a review. So the first step, a number of you mentioned this, is to ask what a patient or family already knows or has already heard. And this is, to find out, is there key information that they are missing or not? And you all know the benefits of this. It ties back to our key tenets of self-awareness. Asking what your patient or family already knows allows you to start from where they're at. It affirms the importance of their perspective and it elevates their voice to promote a more collaborative conversation. So then, assuming that you find out that they are missing some piece of key information, the next step is to ask permission to share more. And asking permission, a number of you put that in the chat as well, explicitly offers control, which goes back to this concept of voice and choice. This can help you slow down again and remain patient or family centered, which is a key tenet of self-awareness and curiosity. And this can mitigate power imbalances and work towards building trust. Again, reviewing, assuming the patient or family is ready to hear more information, you can then move on to sharing information. And I continue to teach, similar to many of you, the concept of sharing information in the form of a headline. And again, a headline is this idea that you provide a brief summary of the medical facts and then add in what it means for the patient's future. The meaning of the information. Some people call this the impact of the information. I sometimes say this is the worry that we have, the deepest worry about what this information could mean for a patient's future. We're not going to talk a ton about headlines today, recognizing it's review for most of you. So now we're going to watch how this common scenario plays out using this case of Quinn. And you might recognize some of the players in this demo. So Quinn is a 4-year-old patient with relapsed rhabdomyosarcoma, which is a solid tumor that's somewhat common in pediatric oncology. she developed some new pain in her legs, and so went in to get some scans, which showed tumor growth with new mets to her legs and her lungs. Her treatment options at this point now include a clinical trial or palliative chemotherapy. The team has shared that they do not believe a cure is possible. Quinn is cared for by her father, Felipe. And what you're going to see is a conversation now between Felipe and Arica, the oncology social worker. Felipe heard this news about the tumor progression last week in a family meeting, and they are now back in clinic, and Arica is planning to check in with them. The clinic nurse tells Arica, I'm really worried Felipe doesn't get it, and she's hoping Arica can help make sure that Felipe understands that there is no cure. So let's see how Arica navigates this conversation, and I want you all now to just pay particular attention to when Arica assesses Felipe's understanding. How does she do that? How does she ask permission to share her update? And then what cues does Felipe give that he both has an information gap and is ready to hear more? And then finally, watch for how Arica succinctly shares her takeaway from the meeting.
Hi, Felipe. It's so good to see you.
Thanks. It's nice to see you too.
I'm glad we're getting this chance to check in today.
Yep.
Yeah. How are you holding up?
I'm hanging in there, I guess.
I can only imagine how difficult the past few weeks have been.
Yeah,
For
it's
you.
definitely been a lot.
Yeah. And how's Quinn doing?
Oh, she's doing a lot better, thank goodness. The pain medicine they gave her is helping. She's back to being her feisty self.
Oh, that's great to hear. That's great to hear. I can only imagine how hard it was when your baby was hurting.
It was tough. Now I'm just trying to understand more about what we're going to do next.
Mm-hmm.
So, what can you tell me?
Yeah. Felipe, I know how committed you are to Quinn's care, and a lot was shared last week.
Mm-hmm.
I would be happy to talk with you more about it.
Thanks.
About what we talked about last week.
Yeah, sounds good. Thank you.
So, before we start, the meeting was very intense and a lot of information was shared. And it'll be helpful for me to understand kind of what your takeaways were.
Yeah, okay. I'm just a little lost in it all. I think they said the cancer was smaller in some areas, but maybe bigger in others. And then they were trying to decide what to do next. It seems like they can't decide between more chemo or to try a clinical trial.
Mm-hmm.
I really don't know.
Yeah. Thanks for sharing that, Felipe. I mean, anybody who was in your circumstances would be overwhelmed.
Thanks.
So, is it okay for me to share what I know about Quinn's cancer and her treatment?
Yes, please. I really want to hear what you know.
So, first, I wish I had better news. Quinn's scans show that the cancer is spreading despite the treatment. And the team said that although there are more treatments, they're worried that we can no longer cure Quinn's cancer.
What? No, that just can't be right. Why would they? There's always been something else.
I know.
She's feeling better. She's, like I said, she's back to being her feisty self.
I know. I could only imagine, Felipe, how hard this is to hear. It's so clear that both of you have worked so hard over this past year.
Exactly. We've been at this for almost a year.
And you've done everything we've asked of you. Everything.
I just cannot believe this. She's my everything. I just can't lose her.
It's so unfair, Felipe. It's so unfair.
Yes.
Okay, so with a moment for for appreciation and gratitude for our incredible oncology social worker there. And just a moment for sort of the weight of that scene. I'm going to go back to our framework and we're just going to march through it quickly. This one should be pretty easy. Type into the chat, was Felipe missing key information there when Arica asked what he'd heard or what his takeaways were? Okay, great. A couple of votes for yes. I agree. When Arica asked what his takeaways were, thanks, Suzanne, he said, I'm just a little lost in it. A little lost in it all. So Arica moved on to asking permission and type into the chat, what do you think? Was now the right time to share more information with Felipe? Yeah, thanks, guys. Yeah, now is the right time. You said, yes, I'd really like to hear what you know. And so Arica skillfully moved on to sharing information in the form of a headline. And here's what her headline was. The information was the scan showed that Quinn's cancer is spreading despite the treatment. Although she could get more, here's the meaning. We're worried we can no longer cure her cancer. Nice work, you all. So that's kind of the default, or oftentimes the sort of the I would say most common scenario here. Now we're going to consider some of the ways that's sort of the way we oftentimes teach this. Now we're going to consider some of the ways that we really need to adapt that framework by examining a few common missteps that we see that clinicians make. So we're going to watch another demo. It's the exact same case with Felipe, Quinn's father. This time, Felipe is going to be a little bit different. You'll see a different version of Felipe. However, Arica has not been to our graduate certificate program, and she's going to proceed with sort of the same framework as before, and we'll see what happens. I want you all to pay particular attention here as you watch to how Felipe is reacting differently.
Hi, Felipe. It's good to see you. I'm glad we have this opportunity to check in today.
Thanks. It's nice to see you too.
How are you holding up?
Oh, I'm hanging in there.
How's Quinn holding up?
She's good. Pain meds are working. She's feeling better.
That's good. I can't imagine what it was like for you to see that your baby was hurting.
Yeah, but we're just focusing on the positive right now. I'm really looking forward to getting her onto the next treatment. We're going to beat this thing. We just got to get moving. So, can you tell me about the next steps?
Sure. But first, can we take a step back?
Okay.
So the meeting last week was very intense. There was a lot of information shared. And it would be helpful for me to understand what your takeaways were from that meeting.
Yeah, okay. So, the damn cancer has spread again. The doctors, they don't think they can cure it. But, Quinn, she's a fighter. And we have God on our side fighting with us, so she'll pull through.
Right. Okay, can I share with you what I know about Quinn's cancer treatment?
Okay.
So, as you know, from her last scan, the cancer is spreading even on treatment. It's a very aggressive type of cancer. And while there may be some additional treatments, they aren't aimed at curing her.
Yeah. I've heard all that. Trust me, I've heard it. I know that's what you all think.
Sorry, Felipe, it's just important to be honest, that we're honest and that we're on the same page.
On the same page? I don't think so. So you all think that you can't cure her. Fine, I'll just take her someplace else.
Okay, so let's work through our framework again with this version. Y'all are masters here. I want you to type into the chat, what was Felipe missing key information about Quinn's prognosis? And type into the chat if you got it. What are the words he said that helped you inform your answer to this question? Thanks, Annie. What are the words you heard Felipe say that help you inform your answer to this question? Was Felipe missing key information? Thanks, Yasmin. Thanks, Kate. Awesome. Thanks, Jennifer. Yeah, exactly. Nice. Thanks, Grady. Yeah, he knew. I've heard all that. I know what you think. Yasmin and Kate mentioned, he said when Arika asked, what have you heard from the doctors? He said, the cancer has spread. The doctors don't think they can cure it. But Quinn, she's a fighter. And so within that sentence, he clearly had the information he needed. So we've talked about this a number of times in this setting. Type into the chat now, what factors besides what the medical team shares inform a parent or a surrogate's sense of their loved one's prognosis? These are awesome. These are incredible, guys. Yes. Their own beliefs, their own perspectives, their prior experiences, their lived experiences, their sense of optimism, their belief about a patient's inherent resilience, their faith, the patient's disposition, past experiences. Suzanne sums it up, the entire psychosocial spiritual context. Exactly. And one of my favorite studies is from a researcher out of Washington University in St. Louis, Brian Sisk. He asked a group of parents of children with advanced cancer that was quite clear could not be cured. How informative has each of the following been in your current understanding of your child's likelihood of cure? And the parents answered like this. Most of them, not all, but most said, yeah, the information I've learned from my child's care team has been really important to inform my understanding of the prognosis. But it wasn't their only information source. Every single parent checked at least one other box. Parents are also taking what they hear from their child's care team and incorporating things like how their child looks, what their support systems are saying, their own processing of information to kind of come up with or create their own estimate of their child's prognosis. And something that is explicitly missing from this particular study that you all mentioned is this idea of prior experience. That wasn't an option on this study, unfortunately. I'm curious if y'all look at this list and think about which of these factors is likely to be influenced by sharing more information. Which of these factors is going to change by us as clinicians giving more information about the child's prognosis? It's really just the first one, right? The medical information from the team is obviously malleable and changeable, and the other ones we have limited control over as clinicians. The last study I shared was pediatric. There's even more robust literature about this prognostic discordance from adult ICUs. There's really incredible work going on here at University of Washington about this. This is from Doug White and his colleagues. This study asked surrogates a similar question to the last study. That asked surrogates their estimate of their loved one's chance of survival in the ICU, and then asked, can you tell me what has made you think this is their prognosis? And again, surrogates were, most of them said, yeah, the information from the team is important, but also how my loved one looks, this idea of intrinsic optimism, prior experiences, faith, a gut feeling, the power of being at the bedside. And a small percentage really named miracles as a piece of what informs them. Really importantly, in that study, less than 2% of people said that their beliefs came exclusively from what the team told them. Everyone that we care for in the healthcare setting is incorporating some aspect of their own deeply held personal beliefs, culture, etc., into their own perspective. And so the key point here is to be careful not to confuse different beliefs about prognosis or serious information with an information gap. And this is one of my favorite quotes from Tony Bach. We clinicians tend to think of information as a fertilizer. If we just sprinkle it on there, awareness will blossom. And in reality, sometimes the opposite can be true, and more information can cause harm and fracture the relationship. I think there's some emerging data that our own implicit biases can also impact who we believe has an information gap. Who do we think, quote unquote, doesn't get it? And this is data from Maya Illowite, who's a pediatric oncology researcher looking at the parents of children with advanced cancer. Again, this data showed that clinicians are more likely to believe that white parents have a good understanding of the medical information compared with Black parents. And while we know that there are disparities that exist in prognostic communication and how we communicate to different populations, some of this, they do not explain this difference entirely, and a significant proportion of this comes from our own implicit biases about who we believe understands. So with this in mind, if a parent is not missing key information, what do we do instead? And this is a complex topic, and for the sake of this framework, the skills that we've chosen to highlight here are reflection statements and support statements. And we've chosen those very specifically. Reflecting back, what we are hearing is, again, the communication manifestation of this concept of affirmation, which is, I think, one of the most underrated or underutilized components of cultural responsiveness. It's a common experience of individuals from historically minoritized communities to have their experience discounted, dismissed, or not believed. And so a verbal reflection of what you are hearing allows you to actively counteract that experience by stating clearly that you see that person and that their experience is real and valid. A strong statement of support can go even one step further to take some accountability. I see you, I hear you, I'm going to support you in the way you are telling me that you need. And so when Felipe says, I know that damn cancer has spread again, the doctors are saying they can't cure it or it's going to be tough to beat, but she's a fighter and we have God on our side, a reflection statement would be something like, gosh, it sounds like you heard the information really clearly last week, and you have an understanding of how serious things are. And a support statement might be, I'm hearing that it's really important that we continue to focus on supporting Quinn in whatever way we can. There are many other versions of these reflection and support statements, of course, as well. Okay, so moving on, we're going to watch one more version of Felipe. And again, this time, poor Arica is not going to adjust her approach. She's going to kind of march down the same path of the framework. Again, I want you to pay attention to how Felipe is different this time. and what happens when Arica does not adjust her approach.
Hi, Felipe. It's good to see you. I'm glad that we're able to check in today.
Yeah, nice to see you too.
How are you holding up?
I'm hanging in there, I guess.
Yeah. I can only imagine how difficult these past few weeks have been.
Yeah, it's been a lot, but just taking it one day at a time. We just have to move forward, on to the next, I guess.
Yeah, of course, of course. So, Felipe, I'm wondering, the meeting last week was really intense, and there was a lot of information shared. I'm wondering if we could take a step back, and if you would be willing to share with me what your takeaways from that meeting were.
Well, with those meetings, it's just a lot of doctor talk. I honestly think I kind of checked out. We always end up doing the same thing. They give me a ton of information. I try to follow them along. Eventually, they figure out what treatment they want to do next. I don't remember much from last week, except they're trying to figure out what the next treatment is going to be.
Mm-hmm. Felipe, I'm wondering, would it be okay with you if I shared what I'm worried about after sitting in on that meeting?
What you're worried about? I don't know. Look, I just need to keep things positive. That's how we're going to get through this.
Yeah, as much as I like to keep things positive, and trust me, I'm all for that, I also think it's important to balance that out with what we know about Quinn's cancer. So, as you know, her scans show that her cancer is worse. It's a very aggressive type of cancer, and we have treatments, but we don't believe that the treatments will cure her.
Oh my God. I cannot be hearing this right now. Not today. This can't be happening.
Felipe, this is a very aggressive cancer.
All right. I know.
I
cannot have this conversation right now. Not today. I have too much going on.
Okay, so let's go through our framework one more time. Go ahead and type into the chat. In version 3, was Felipe missing key information about Quinn's prognosis? And what did he do or say to help you determine your answer? A couple of different thoughts in here. Jennifer mentions he felt overwhelmed with all the information and was unable to process it. And then, Annie and Yasmin point out, maybe it's a little bit hard to tell. His insistence on keeping things positive, maybe he heard it, but he just doesn't want to talk about it more. So it's possible. I think when Araka asked him his takeaways, his line, as Jennifer pointed out, those meetings, they're just a lot of doctor talk. I don't remember much. So certainly we had reason to believe as a clinician that that he may not have all of the medical information clearly. It might not be totally clear, but at least when we, in that initial grasp of that assess question, we have reason to believe that maybe he hasn't heard it all. And so we move on to asking permission, and a number of you already put this into the chat. Was now the right time to share more information with Felipe? Definitely not, right? He gave a number of cues, actually, both before and after Arica explicitly asked him permission to share more and said something along the lines of, I don't know, I just need to keep things positive. That's how we're going to get through this. So he was giving off plenty of cues that at least in this moment, information was not what he needed. Jennifer points out he seemed uncomfortable from the start. Yeah, maybe today wasn't the right day. We don't really know. So let's take a moment and think about where we are in this framework. We have a belief that a patient maybe doesn't have all of the information that they might need to make decisions, but we're also getting cues that right now it's not the right time to share it with them. Put yourself in that situation and type into the chat, how does it feel when you know a patient or you worry a patient or surrogate is missing key information, but you're not supposed to give it? How does that feel? Yeah, thanks, folks. So it feels, thanks, Kate, for maybe it feels even a little bit dishonest. Feels really tough. Sarah points out in particular, if there's some acuity to making a decision, then we really feel uneasy about it. We've learned, right? For many of us have gone through all of our medical training, kind of learning that it's our job to give patients and families as much information as possible. So it can feel really counterintuitive. There's this sort of internal push to get that information out there. One of our graduates who helped us a little bit with this work kind of mentioned that sort of the duty she also feels to her colleagues when she's about to go off service. She doesn't want to feel like she leaves an open box of, somebody's got to tell this patient their prognosis. I didn't do it. So certainly there can be a lot of pressure that can make kind of stopping in that moment more difficult. We know, however, a number of you mentioned this, recognizing a tension or a preference or an ambivalence around talking about serious news. It takes self-awareness, but ultimately is the key to promoting voice and choice and eliminating those power differentials as much as possible. And so when we see a parent or a surrogate show this overt or sometimes even more subtle hesitation, the risk of re-traumatization is high. And so to be accountable to their needs, we have to take an alternative approach. We may still share information ultimately, but we have other work to do first. And so again, here we've chosen to highlight really those same key skills of reflection and support. And so here, when Felipe says, I don't know, I need to keep things positive, a reflection statement might look like, gosh, it sounds like right now, knowing all the information isn't what's most important. Sounds like you really need to focus on the positive today. A support statement might be, as your team, we're going to honor what you need in this moment. I hear you, and I'm going to support it and honor and do everything I can to get my team to support it as well. So one more thought for you all. Go ahead and type into the chat your last time. Why might a parent or a surrogate not be open to hearing more information? What maybe was going on with Felipe in that last version or with other families you've cared for when they're not ready to hear more? Thanks, David. Maybe they already know it, but they aren't ready to accept it. They don't want to talk about it more. Yeah, maybe they need another family member or a support person there. Jill, I love that. Maybe it's just a bad day for this. Yeah, maybe they're worried about the implications. They just are, yeah, sure. There's some deeper worry about what it might mean if this is true. These are great. You know, there are so many reasons why. The point is we have no idea, right? What's going underneath that hesitation or ambivalence about hearing more information. We might have some guesses, but we don't really know. You know, we tend to see sort of what we've lumped this into like kind of 5 major themes. I'm not sure if these are the exact right ones, but these are sort of some of the themes we see. One is circumstances. One of you put that in the chat. You know, I need my partner here, or I need somebody to watch my other kids so I can really pay attention. Another one might be just emotional overload, right? I just can't handle more bad news today. Parents and surrogates are often managing many emotions during stressful situations. And this can be a healthy coping mechanism to kind of pace these out. There may be a need to develop more of a sense of trust with the clinician before they're ready to hear new information from them. This might not be somebody that they have gotten to know or trusted at all. You know, there's some small but real subset of families who approach decision-making in such a way that more information may actually not be helpful to them and will not influence decisions regarding their child or their loved one's care. And then I think we sometimes see patients who really prefer an indirect form of communication, and some people tend to practice this indirect communication. And so talking explicitly or even directly about this what if might be unhelpful or even offensive, or otherwise not well. And so if a parent sets a boundary about information sharing and we're able to diagnose they're sort of not ready, in order to be accountable, we have to take action based on what we learned. And so, for example, if the issue is circumstances, can we reschedule? Can we get them the support and resources to help make this a better time for them? If this is a emotional overload situation, can we just, you know, use our nurse statements, go back to the basics of communication and slow down a little bit? Sometimes I have seen families just, you know, they have to work through the emotions of their ambivalence or their worry, and then they do in fact want to hear the information, maybe not, but can we slow down and allow some space for that? If we are sensing that there's a challenge with trust, or that we have yet to earn that patient's trust, can we affirm that that is a fair and reasonable perspective? Can we rely on our team, help figure out who has built more trust with this family? How can we do our own work on our side to continue to work towards earning trust? For families who don't find this information helpful for decision making, again, can we affirm their perspective, the way that they make decisions? Can we document this in the chart so that we can figure out how to avoid continuing to ask and ask and ask to share more information, or try to share more information with families who don't find that helpful? And again, for a family who prefers a different type of communication, again, can we affirm their perspective, their experience? Perhaps we can explore a little bit, how might we talk about these difficult topics, and document in more detail their information preferences. And so that's it. That is, we have worked through the framework together. Excellent work, everybody. I'm just going to give one more thank you to Arika for her incredible acting. The last two scenarios in particular were challenging for Arika because it is not her it is not her default as an incredible social worker. So thank you to Arika for that, and to Caroline, and to our incredible advisory committee of folks from across the country who have helped us with this work. And I'm going to put up that QR code, trying to get promoted in the next couple of years. So give me an evaluation if you can, and I can take questions. And I see a question from Elliot in the chat. How to approach this when the position of not being able to hear things extends days and weeks. Yeah, thanks so much, Elliot. It's a great question. Elliot's one of our neonatologists, and worries about, yeah, how do we approach this if this is going on and on and on. And I think it's a complex question. You know, one of the things I wonder about in those situations is how often patients and families really have had their perspective affirmed and respected over time, and really have they been listened to and heard in a deep way, or have we sort of said we're going to honor that but sort of sneakily tried to share information in other ways? You know, it's hard to get an entire team to kind of honor this framework in a way, and there's oftentimes ways that we can kind of covertly try to convince families of hearing information they're not ready to hear, or you know, making decisions they're not ready to make. But it's a complex problem, Elliot. Thanks y'all for being here. I know we only have a minute or two, but if other folks have questions, feel free to pop them in the chat or unmute. And otherwise, it was lovely to see you all.